of us really at the leading crest in many aspects of cancer research in this city and in this country. Kathy Pritchard is known as the Popess of oncology worldwide, so that's pretty kind of good for you to have her. And Martin Yaffe has often been touted as one of the guys who should get a Nobel Prize for medicine for his work in imaging. So you really do have some extraordinary people on board. In this city, a few years ago, we ran a campaign to develop some sort of biomarker campaign for inflammatory breast cancer. And really, this was at the very nascence of all biomarker research. And as might have been expected, we sort of ran into brick walls because there wasn't enough sort of real drive to sort of figure out the idea of biomarkers. There wasn't enough sort of technology to sort of get all this out. We also ran a drive to develop databases, and that required an awful lot of other input. These are ventures that we've taken off on, and I want to illustrate the fact that we've generated a fair amount of information from our databases. But more impressively, what I really want you to know is that the Foundation has worked with us to bring visions forward that actually predated many other people's visions. Okay? We're only as good as what we can measure. Now, getting back to the point at hand, so I think you've got sort of, I'm glad that you're sort of at least sponsoring this evening and thinking about this. This is a crucial area in all of medicine, I would say. I'm not a huge fan of the concept of personalized medicine, not the concept of the wording of it, because it gets bandied around far too much. So I think we can get back to basics, and that is, I loved your concept of, the right drug, the right person, the right dose, the right time. Biomarkers in breast cancer, or in any cancer, and we'll only speak of cancer, okay, is either one that's oriented towards saying you have the disease or not. Martin Yaffe's work is oriented very much to that. Use a PET scan, inject a dye, there's the disease. We can't see it with the usual test, but there's the disease. Or take a blood test, measure the protein, there's the disease. But you need to be really certain, because a well patient who has nothing wrong with them, you go, my God, you've got cancer today, you better really, really, really have a very high positive predictive value. That's the word that's used. That doesn't exist right now. The second one is to say, you got the disease, and now how do we expect this disease to behave? Are you going to live or are you going to die? Are you going to relapse or what? And in breast cancer, traditionally we've known already that patients who have estrogen-positive breast cancer will actually behave, their cancer will behave indolently, but still not get cured a whole lot, but will behave indolently. And patients with HER2, another word, HER2-positive breast cancers, their cancers will behave hyper-aggressively, and they will relapse very rapidly. More recently, I think you've cottoned onto this triple negative. What that means is that none of the markers we look for in the cancer cells are present, the ones that we know to look for. And those, 20% of those patients will relapse in the first year. Okay? So that's kind of really important to know. Do you have a marker that predicts how the disease will behave? Prognosis. Markers in breast cancer have more commonly been used to predict what do we use to treat you. If we treat you with this, do we predict that this treatment will work? And the traditional treatments that we use in breast cancer after surgery are radiation. No such marker has yet been explored to look at radiation because it's kind of not been the most imperative thing to look for. So if you were going to put money into looking at radiation and the effects of radiation, I'd say, you know what, that's not the big question. The big question is, will you die of cancer if it comes back? And by intervening, if you have a cancer that is estrogen positive, the predictive factor that hormone therapies will work is very high in reducing that death rate. If a woman has a HER2 positive breast cancer, remember this is the one that many women died very quickly, this disease has been turned around simply by using the drug Herceptin. So this drug applied to this disease has changed forever the course of this disease. So those biomarkers in this context were used to not just prognosticate how aggressive was the disease, but also to predict how a certain treatment would work. A woman with estrogen-negative breast cancer will not do any differently if you gave her hormones. A woman with HER2-negative cancer, zero effect of giving her Herceptin. But the disease is turned around if you use a specific treatment for a specific marked disease. Now, the other traditional way of treating breast cancer has been with systemic therapy. We've talked about hormones a little bit, but the big guns that no one wants to use are chemotherapy. Just an hour ago, I was talking to a 27-year-old woman who has breast cancer, and she said, "I don't want chemotherapy." And I said, "I don't want to be the doctor who tells you you have to have chemotherapy, but that's what I have to do." So here's where the whole, this is the most feared type of treatment. It's the most dangerous treatment that patients can get, but when given correctly, it can be the most beneficial of treatments. So those patients, let's say, with triple-negative breast cancers, the ones that don't have any markers, those are the ones that actually you can really start to turn around just with chemotherapy. But who is it? All they're defined as by this surface of triple negativity, and we don't know who they are. So chemotherapy doesn't have any predictability right now. What you can say is that if the cancer has certain attributes, you can use chemotherapy or you can use hormone therapy or you can use Herceptin. I just want to sort of mention, do I have a couple more minutes?
2 minutes.
Sort of mention
She is.
a couple of other points. This is complex science. The disease is heterogeneous, and the face of people who have the disease is very different. There are racial differences, ethnic differences, geographic differences, etc. So that's one thing. The disease itself, so that's in the person. In the tumor itself, it's different. You look at it on the surface, and you can say, well, this is an estrogen-positive breast cancer. Good. That's the surface of the cell. Estrogen positive, HER2 positive, not positive. But what has been challenging is now to get below the surface of the cell. That's where you're talking about proteomics or genomics. So now you're looking to see, of this group of women, 100 women have breast cancer, 20 of them have triple negative breast cancer. That's all you can say from the surface of the cell. But now when you get under the surface of the cell, you start to look at DNA and RNA, etc. You now know that of those 20 women, one would hope, you have 5 women who have something that says chemotherapy will make a difference in their disease. You have 5 women that will say, it doesn't matter what you give them, nothing's going to happen. And you have 10 women where you say, well, there's going to be you need to sort of use another treatment. So when you use taxanes, the only thing we know with taxanes is that they seem to work if you're HER2 positive. That's that 38% group of patients that seem to be benefiting from it. If you look at anthracyclines, another group of medicines, there's another enzyme that people have looked at. Those are the only predictors that we know that might save it, and they're just way too irrelevant. So the time is ripe to really start to look at a definitive way of saying, at the beginning of a diagnosis, is there something not just on the surface, not just about the person, i.e. old versus young, or on the surface of the cell, but now is there something in the inner mechanisms of the cell that will tell us about the success of the tools that we have, or the tools that we should develop. And I think this is the right thing to do. This is truly the trend. I think you will need large databases to really confirm and develop this kind of thing. The will has been there to always do this kind of work, and I think this is absolutely the cutting edge. The very final thing I just want to say is it's easy to confuse the concept of curing cancer, and I just want to be very clear that the cure of cancer always in breast cancer actually starts and has to be focused on early stage disease, newly diagnosed disease. It's not appropriate to start bending this into women who have really advanced, fourth, fifth line, like diseases everywhere. This is where the money's at. The early stage of disease, treat them right, and there's already been a profound difference that's been made by the right treatment, and that's where the next step is.